I had a talk this morning, educational, on a sequence of treatment in relapsed refractory myeloma, because now there are various options we have, different classes, and we learn more and more that the choice is important in a relapsed refractory setting and depends on numbers of variables that include how you treated the patient initially at diagnosis in the upfront, in the first line. So to make a long story short and to make it simple, we have breakdown the decision making on the backbone. To talk about the backbone first, based on the treatment given previously. So at first relapse, if initially you had Revlimid, you're gonna favor a change, a switch of treatment, not necessarily to reuse Revlimid, but to use a bortezomib based, or more and more, a PI, proteasome inhibitor based regimen. If you started PI, you will absolutely not reuse the same PI. You can change PI, for example, Velcade to carfilzomib, which is the Endeavor study, or we demonstrated the efficacy and the benefit of reusing a PI, but a different PI. Or you can go from a proteasome inhibitor to Revlimid to change completely the class and the mechanism of action. We know today that retreatment with the exact same drug is definitely not beneficial to myeloma and to optimize the treatment. While in parallel, the most important impact you can have on survival for the patient comes to the first line and the early relapse line. So if you miss the early relapse line, you will be in trouble with trying to prolong the survival of the patients. Now, the second piece of information we gathered over the years, and particularly recently, is that most of the studies were run demonstrating that the more is better is myeloma. Triplet-based regimen is better than doublet-based regimen. But still, for cost reason, for age and frailty reasons, for safety profile and quality of life reasons, there's still patients who would benefit, who should benefit, and it is our job to find out which patient could benefit from still doublet-based regimen, because we cannot say we're going to give triplet to everyone. So there are now data helping us figure out that, for example, if you start a doublet-based regimen and you reach CR or VGPR, at least with Revlimid, likely you're going to do very well. And then you may not need a triplet-based regimen. Or you can start doublet, and later on, if you think the depth of response is not the one you expected, then add the triplet. Last, not least, we have now clear demonstration that depth of response is an early endpoint, that it should be the goal for all patients whom you'd like to treat with a cure as a primary mode of action. Of course, patients whom you want not to, you just want to control myeloma because they're very old or very frail. Of course, the notion of cure is away from that. But for the rest of patients whom you really want to prolong PFS, you really want to prolong over survival, now you have an early endpoint. And that early endpoint is complete response at best, minimal residual disease if you can. Now, there are various levels of MOD in myeloma. You could shoot for MOD 10-4. It's a flow cytometry, bone marrow aspiration plus PET CTs. You could do in all the centers. It needs 6 to 8 colors. Of course, MOD by NGS and NGF, which relate to an interview we had 2 weeks ago in ASCO, it's more complex. But everyone in most of the centers, at least in a country like France, at least in most of the academic centers in France, could do 10⁻⁴ MOD. So the three markers, switch, drug, potentially class, mechanism of action, triplet, and an early endpoint depth of response will secure the treatment and the sequence from first line to first relapse. Now, the end of my talk was that there is a gray zone. There's always patients that just do things differently. Example, you have a patient you treated 7 years ago, and the patient had a complete response, free of relapse for 7 years. and the patient got bortezomib-based regimen. You could say, well, the patient was 7 years free of disease, I'm going to give bortezomib back. And well, yes, you could. Now, the data says that clearly you could, either with bortezomib, same story with Revlimid. Clearly you could, but the data will always be slightly not as good. So still, the message is don't do it. But gray zone, and if the patient wants, there are situations where it's not necessarily an error, a mistake to do it. But you expect definitely not to get a better result. And if you get the same level of results, you're in a certain extent very lucky. The end of my talk was to say that what I'm talking about now is likely going to remain true, I would say, hopefully, for the next 2 to 3 years. But in 2 to 3 years, you're going to have to wipe this out and go for new context, new way of conceptually seeing things. Because we're going to use triplet-based combination, PI plus IMiDs up front. So then the sequence will likely not come to, I'm using IMiDs, so I will use PI, or I'm using PI and I will use IMiDs. It will come to ideal combinations. And you will think in terms of ideal combination. Potentially, you will go for PI IMiDs and then monoclonal antibodies IMiDs. Or maybe you will go for PI IMiDs and then a different PI plus monoclonal antibodies. So you should expect the future to keep the sequence, keep the notion of sequence, keep the notion of triplet, but shift a little bit in the exact drug we play with in the sequence. One last word, precision medicine. Today, more is better, triplet is better, etc. But you must be expecting that the future is to use precision medicine for certain subgroups of patients where finally we're going to be able to find one drug that could control the disease. We know in myeloma very few patients match this particularity, which is at the opposite to a disease like chronic myeloid leukemia, where most of the patients could be sensitive to one ITK. In myeloma, it's extremely rare. But there are patients, for example, T1114 patients, we know an anti-BCL2, a drug like venetoclax, could very well single agent control the disease. But in general, for example, keeping in mind the venetoclax example, all the patients which are BCL2 high, MCL1 low, could actually potentially benefit from venetoclax. So precision medicine is one of the best ways. We have to keep having the same level of control of the disease, but on a much less costly way, because we will be using only one drug instead of 2 or 3. And this is tomorrow. So for all these reasons, what I'm saying right now is only true for a couple of months, and bye-bye.